I invite Dr. Manoj Singh sir as moderator. He is consultant and academic coordinator, Department of Respiratory, Critical Care and Sleep Medicine, Apollo Hospital, Ahmedabad. His area of expertise is pulmonary critical care, pregnancy and critical care, toxicology, interventional pulmonary medicine, and lung rehabilitation. I invite the panelists on the dais, Dr. Bhalendu Vaishnav sir. He is Assistant Dean, Clinical Services, Professor and Head, Department of Medicine, Pramukh Swami Medical College, Bhai Kaka University, Karamsad. I also invite Dr. Shrikant Sahasrabuddhe, Senior Consultant, Intensivist and Pulmonologist, Medicover Hospital, Aurangabad. I now invite Dr. Srinivas Samavedam, Head of Department of Critical Care and Medical Director, Virinchi Hospital, Hyderabad. He is Vice President, ISCCM and Associate Editor, IJCCM. I also invite Dr. Ajay Kothyala sir, who is Senior Physician of Anand. Welcome, sir. Sir, please start.
Thank you, ma'am. Good afternoon, friends. So those who are sleeping actually have a very good well-being today. So I've seen few people sleeping already in the previous session. And thank you, team Gujarat Criticon Karamsad, for giving me this topic. And few thoughts definitely rolled on when I was called by Rachit and team. That I said probably it's not my domain. My family said you are making a joke of yourself by telling in front of people which you don't do it. And most of our colleagues don't do it, so people think that we will retire and then do it. Because probably when we became intensivists, we thought it was a domain of a radiologist, ophthalmologist, pathologist, a branch which had timelines and no emergencies. But having said that, when I ventured deep into this topic, definitely few things came to our mind, and when I had a chance to interact with two new people in my life, Dr. Bhalendu and Dr. Ajay. So definitely it's a message, and it's probably a good initiative by the team to keep this panel discussion. So first few theoretical things, then jumping on to the practical things. So what is work? So unfortunately it is linked to your monetary gains. It's a physical or a mental effort which you put to complete a task. And this monetary earning which you have can or may not be supplemented or complemented by non-monetary benefits. So that's how you work today, or you work in your life. Life refers to the state of existence which is characterized by various drives and desires which you generally are sitting and thinking, or you came with that mind, thought, and of probably which you'll take home from today. That will be your sort of desirous life. So what is work-life balance? It is definitely a vague and complex phenomena. Many of you who are new or who have just passed will say, let me throw this, પહેલા પૈસા કમાવો તો પછી વિચારીશ. That's what you will have. Or આ બધા વાતો કરે છે, કોઈ આ કરતું નથી, because you have all seen us working at our workplaces. Greenhouse was the first thing which defined it, that to an extent an individual is equally engaged in and equally satisfied with his or her work and family life is probably a balance. And how do you perceive it? See, we all don't need to have any great gadgets, because our own body is the greatest gadget, where balance is achieved and perceived and maintained by a complex of sensory-motor control systems that include the input of the vision, the touch, the vestibular system, and finally the integration of the senses. So that is how you probably have a well-being or a balance. But you all know, we all are born Bahubalis. You know, we all are born Bahubalis, because we in intensive care unit are faced with the wrath of system or complex lives from us. And from day one, Katappa is our friend, because that's our burnout syndrome. So the day you are born in an ICU as an intensivist, you are faced with that stress, which is probably called as burnout syndrome. So burnout syndrome was actually defined in 1970. It was for healthcare workers, actually found out to have a lot of correlation with anesthesia colleagues 4 decades back, but then it has been translated to intensive care. And I'm sure all of you will agree, many papers have been published in the last 2 years about burnout syndrome, in intensive care unit for during COVID pandemic. And most of you have got a questionnaire which is from the MBI, the Malag and Jackson questionnaire. Please enter your own burnout score and give it to us. So we have circulated among the delegates MBI questionnaire. Please fill it. It is an anonymous, you don't need to write a name, and it has been made by my colleague Dr. Ritesh. Please fill that form, and we would like to see your stress level. And many complex phenomena from tiredness, headaches, irritability, your own colleagues are dissatisfied with you, your family is always dissatisfied with you, are probably a combination of symptoms of burnout. So now let's go to some real life scenarios and see how do you cope up. The first time when we became intensivist, we had a new admission coming in out of odd hours. So I'll ask Dr. Srinivas, how does he manage a patient when it comes in odd hours? Does he relegate his team to do it? He doesn't even take the call? Or does he do tele-ICU? Or he run for a life-saving measures? Srinivas.
First of all, a declaration I would like to make. Some of the things which I may say how I manage this peculiar problem is not what I practiced ever since I became a consultant. Some of these things are some things I have learnt by mistake, by trial and error, breaking my kneecaps, probably having paid a price for overstretching myself. So at least from experience, I would like those who are entering this field not to follow that path. So it's a declaration of a conflict of interest. Some of the things I have done, I'm going to say maybe I should have done, but I haven't done when I was younger. At this stage, when there is a new admission in the odd hours, I rely on my team. I rely on my team to assess the patient. But yes, information technology has advanced so much in this country that every single patient I have in my ICU, even sitting here, I was able to see what every patient's noradrenaline is, antibiotic is. If my team says so and so is not doing well, I have the luxury of looking at telemedicine and using it. I'm not a believer that you are the only one. If you are working in a place where you are the only one who has to run to save somebody's life, more patients will die in your ICU. You need to develop that culture of training the second rung. You need to give that confidence to the person on the floor. I know Manoj and me worked in the same unit several years ago, decades ago. Like we used to be the only person on the floor for managing a 16-bed ICU with a junior for support. But that was a confidence. We were trainees in FNB at that point of time, and our seniors had the confidence in us that we could manage it. So it is every team leader and every person who gets into intensive care should come out of the mindset that you are the only one who can do good for the patient. You should encourage more and more people to do things the way you do. If I can ventilate patients well, it should not die with me. I mean, there should be a second rung who will teach the third rung. That is my idea. So I don't run for doing life-saving procedures. I know that there is somebody who is doing a life-saving procedure, but if that person needs help, I must be available, or I must designate somebody to be available.
Okay. Shrikant, do you run for counseling since you have just started a new venture and you are the director of Medicover? And how about your organ-specific colleagues? Suppose your patient has come and has developed an acute kidney injury in the night, and relatives say, Shrikant ko bulao, tabhi dialysis shuru karenge. How do you handle?
Right. So, I think I would just kind of go on with continuation with what Srinivas said, that we are sitting here doesn't mean that it has to be just followed what we say. We have also learned from the mistakes, and we still are learning. And I think I always quote that the quote which I always like is, live as if you have to die tomorrow and learn as if you have to live forever. So I think this learning process goes on continuously. There is no end to that. And coming back to this problem of counseling now, this will have the dynamism of the place where you practice. the city where you practice, the hospital where you practice, and the patient's background, the uh, their their social standing, the criticality of the problem. So there are many problems or many facets to that. I would like to discuss or probably talk of a situation where the patient is probably young patient who has come in odd hours and come for one particular person. Unfortunately or fortunately, I feel the practice which has been developed in our country is doctor oriented practice, and I think we are also happy in saying that okay, this patient has come on my name. Now we are following what our seniors did, and we are probably proud enough to tell, okay, there are these 10 patients are my patients. That gives you a sense of elation, and you feel very happy at the end of the day when you go with 15 admissions under you. You are top of the moon. But I feel there is, I mean, I always feel in this kind of background that probably if our system would have been a balance of a doctor based versus a hospital based practice, if not completely organization or institution based practice, or the patient coming to the hospital. I mean, there are cities, in the metro cities, of course, the patient comes mainly for the hospital most of the times. But the place where I work, even though we have a corporate hospital, this is the first one, and probably you caught me at a correct time when I'm facing too many problems which I never ever have thought that this can happen to me. Coming back to this issue of counseling, yes, so if I am practicing in a tier 2 or tier 3 city, and the patient has come to me per se, uh, yes, if the family demands, I have to go. There is no doubt about it, because if the patient dies in the night, then then you had it. Talking about the organ specific colleagues, yes, again I think it is about how you think that how ideal you should practice. If you feel that a colleague is required, or a cardiologist or a nephrologist or a gastroenterologist is required, I may definitely be open saying that okay, you call these three specialists. But here there is a very thin line between what an intensivist does. Does he do a job of a traffic police, that okay, creatinine 3 nephrologist, bilirubin 3 hepatologist? You may not do that, but in a correct sense, I think I would definitely be open to involve the organ.
Right. So let's move on. Next, Dr. Bhalandu sir, you work in a big institute. What happens if your patient comes and dies within 6 hours of admission?
Right.
And you have not seen the patient. He just came, you just reached home, you said, I'll see tomorrow because you're the HOD. But your team is managing, he dies within 6 hours of admission.
Right. I think we have come
It's a very
across
important scenario.
such situations earlier, and I think it's a human tendency that a person will accept death. It one can swallow.
Okay.
But the situations under which death occurs
Right.
is difficult to swallow.
Correct.
Because death is a reality.
Yes.
So that requires a good listening,
Right.
and then communication like a healer. I was reading a book of Burney, and he has described 3 healers. One healer, he says, a hurtful healer. I mean, he is not healer, but hurtful. So he will say, કે તમે કંઈ ધ્યાન નહીં રાખ્યું ને નિગ્લેક્ટ કર્યું, મોડા આવ્યા, મરી જ જાઓ ને. So, I mean, એક તો વાગ્યું અને એના ઉપરથી ડામ, દાજા ઉપર ડામ. So he's a hurtful healer. So one shouldn't be that. Second person is an indifferent healer. He speaks like as if you have a pre-recorded voice, that we have done everything and then nothing has happened and we tried and now he has died. So he is an indifferent healer.
Okay.
Third is a real healer.
Okay.
He looks into the eyes of the patient, puts hand, say that I do understand your grief. I have seen one of my colleague. He was a colleague, and the patient died, and his son was crying. Sudden death. then listen, he said that माँ बाप कभी मरते नहीं हैं. So you see, when somebody, the parent is, father is gone, the healer says that maybe his body had to go because of this disease or that disease. But his feelings, his memory is always in your heart.
Right.
So there are ways of communication
Right.
in that. Now I think if we can
I
have.
think, Ajay sir, what about you when that patient
See, all these people, they are like working in institutions. I am 70 years old, so maybe in this audience there is none who has done 40 years of critical care. And many things to me from my own experience are just theoretical, because I was the first to start a small 6-bedded ICU in Anand way back in 1992, when many of you were not even born. Now it was a solo practice. The corporate culture did not exist. The only other ICU was in Karamsud Hospital where Balendu works. And at that point of time, that was also a 6-bedded ICU, very small one. There were no specialists, no super specialists. So all that journey, that if I'll tell you, you will find it interesting. In 1992, when I tried to get a pulse oximeter, I had to get an import license. You can't buy a pulse oximeter without an import license. You can't buy a ventilator. Those were the days. And then starting from there, we went on, moved on. We started pulse oximetry, ventilator, blood gas, central oxygen line, and so on. But the question is of odd hours. See, at that point of time, I was all alone. I run the OPD, I look after the hospital administration, and I also look after the ICU. I also read, buy an ETCO2, read. But when patient comes at odd hours, honestly I will tell you that I had to run myself. For many days together, I have run in the ICU at night. But those were the days when patients regarded us as semi-gods. In the initial years of my life, I never had any problem. Somebody died, they would appreciate, Sahib, તમે તો રાત્રે આયા બેસી રહ્યા 2 કલાક. તમે આયા બેસી રહ્યા, એ અમારી માટે બહુ છે. But those days are gone now. Those days are gone. Those times there was no CPA, there was no criminal negligence, nothing. But still, after all these years of practice, I believe that individual practice of critical care has no place in society. It must be a team. But when I started, there was nobody else to do it. I will tell you one other incident. I was the first GBS patient in 1992. Young boy, affording patient. I sent the patient to Bombay Jaslok Hospital. In 93, we started ventilating patients. In 94, we started doing GBS. In 1998, we started doing plasmapheresis. Then we started doing hemodialysis and so on and so forth. But see, times have changed. Every day is different. Every day, as the times go out, patients' expectations, families' expectations, everything changes. But honestly, I will tell you, work-life balance, yes. But when you are all alone, in a whole city of Anand, there was not a single ICU. All other physicians, surgeons, even I have experienced that trauma patients from orthopedic surgeons would come to me, because there was no ICU, there was nobody having blood gas, nobody having a ventilator. So I have slogged like anything all alone, but that is not the right thing to do. I had no choice at that point of time. For almost, I would say 12 to 15 years, there was no ICU in Anand. Right. And the first corporate hospital in Anand, in Gujarat itself, came up in 1996. That was Sterling Hospital, Ahmedabad. So no, that culture of small nursing home, doing everything yourself was there. There, I have done it, but not a wise way of living.
Right.
And I think that I have made a mistake, but none of you should make it.
Right. Srinivas, how about you? When you are out of station now and your patient dies, how do you take this? And
Well, there's nothing I can do.
Traveling and patient.
But yeah, see,
patient is admitted under you.
yeah, patient, as he said, it is my patient, right? I don't have that concept at all that this is my patient. First point. I generally, when I travel, I introduce, my team is anyway introduced to the patient on the day of admission, and I will introduce all my consultants who will be speaking on and off to the family. The day before I leave, I will introduce one of the senior consultants and say, I'm leaving, I'll be back on this day, and so will be speaking to you in my absence. And even for my team, when I have a plan to travel next month, for example, I will tell them well in advance that these are the dates in which I am not available, so that some of my senior consultants adjust, or we ensure that one of them is there. But if they die, most of the time they accept it because I have already spoken to them. Sometimes they're in their grief, they will ask me for they ask to speak to me. I do a video call and speak to them.
Okay. Thank you. I think with the advent of time, let's move on. Balandu sir, your inputs on being humane.
So, one thing I would like to say is that when there is a straight line on the monitor, the role of a physician doesn't end, or an intensivist.
Correct.
There is more to do. I think in last conference, Dr. Abhishek probably mentioned this paper, or there is a in Criticare book that is there. We institutional practice which we call a Code Krishna.
Okay.
So what happens is that the treating team will stand by side of the deceased patient, have a floral tribute, and pray.
Okay.
In a sense, it is creating a silent space in the ICU. When you simply stand up in front of a dead body, putting your stethoscope away and pray, it creates a silent space. So many verbal violences will just drop. Patient may have many complaints. They all will drop.
Yes.
And so this last one, he was our resident. It's like carrying the lamp further. So if you do it in a medical college, one who passes out, goes to another medical college, will also learn from it. So this is a way of handling or adding the psychological, spiritual care.
So I think very nice take-home message. I think all of us should do this. We have not been doing it. I think let's pray to the departed soul. Very nice, sir. I think we will imbibe in our clinical practice. So let's come back to our own self. Can you tell us what are the causes of a physician burnout?
Right.
Why do we burn out?
Right. I think all of us panelists will agree and thank the organizers that you all come here, all of you come here so that your patient care improves.
Correct.
But this panel is for you. It is not for your patients. Kotiala Sahib also said, this panel discussion is for well-being of our own colleagues.
Correct.
How many of you are above 40 in this audience?
Above 40.
So, I mean, the answer which I wanted to know was opposite, that the remaining are below 40. And those who are below 40, remember we teach our students that in infancy these are the common diseases, young adult, childhood, these are the diseases. So certain work-life mismatch will happen in life up to 40 years or 46. Standard said is 46. So let us accept that certain discomfort will happen. If somebody says it is not happening, probably he is lying.
True.
And let us remember that perfection is not an extreme. Perfection is balance, an equilibrium. So whatever you have plus and minus, if you can manage it well, then it is perfection for that stage. So if you know this, then I think there is a smooth going.
Right.
Now in I think Buddhism there are 3 whys. If you ask the question why 3 times, then you can go to the root of the problem. So why there is burnout? First is there are external reasons, that workplace, technology, society, competition, workload, etc., etc. They are in a way associations. Say in research, they are associated. There is no causal relationship. They are associated. Second is their personal reasons. Compelling obligation to family, work, anxiety, depression. They are correlations. You can correlate.
Okay.
That because of this, there was a problem.
Right.
So
Correct.
that is second. Third is there are deeper reasons. They are existential. One can prove by regression analysis, to use this statistical jargon, that if your spiritual IQ is less, if your emotional IQ is less, if you don't have a larger vision, if your aim is slightly compounded by other factors, then you have it. So if you solve only one, solving one is like taking paracetamol.
Right.
For malaria or for any infection, you can clear, it will not get cleared, believe me.
Correct.
If you have second and third, then maybe there is some chance. Thank you.
So I think that's a take-home message. Now, Ajay sir, 40 years of intensive care, working alone in a 100-bed hospital as the lead and team member, director. What are your effects of burnout? Have you had burnouts with family, colleagues, work culture, efficiency? How can you tell your story in a nutshell in this slide?
See, let me be honest. I never had burnout.
Wow.
I never had burnout. And let me again be honest. I used to work on an average 13 to 14 hours a day for 30 years. I never had any burnout. Now actually people ask me, even in my, there was some team of IRMA, because 100-bedded hospital, single individual. Today I am having about 22-bed ICU. And people ask me, how do you not have burnout? Then I tell them a small story. See, once I belong to Himachal Pradesh. So once I was going trekking. I'm very fond of trekking. And I saw a young girl of about 12 carrying her small brother on her shoulder. And then I asked her, are you tired? She said, no, ye to mera bhai hai. So what is your approach to work? Is the patient a burden? Is your work a burden to you? Or is it a joy to you? I feel today, honestly, I am the luckiest person on earth. Why? Because my passion is my profession. Whatever passion I have in life is my profession. At the end of the day, of 14 hours of work, I am not tired. Why should I be tired? For me, that work is play.
Yes.
So, honestly speaking, I have never tired. In fact, I keep on learning. Lately, my daughter is a neurologist and I started learning EEG at the age of 70. So, for me, there was never a burnout. But if you ask me why there is burnout, I will tell you. You are not keenly interested in your work, 1. You don't love your work, 2. And you feel your work after sometimes become a burden.
Correct.
If you think of these things, that my work is not a burden, I love my work, then I feel that there is no reason for any burnout. Only thing is, we get stressed out about consequences, about the result. See, when you work like me, 14 hours a day, without bothering what will be the consequences, how much money I will earn. I have earned very little money compared to the number of hours I have put in. But if you are not worried about outcomes, whether people praise you, they blame you. I had cases where I was called to the police station, I had court cases. But when you are not worried about outcomes, you focus on the process of your work rather than outcomes. In my opinion, there will be no burnout.
Right. Okay. So, Srinivas, how an intensive care should design his own work so that he remains a single point of contact for something, but not all? What are the core areas so that the stress doesn't come on a daily basis?
See, in a team, there have to be multiple single points of contact. There are nursing related issues. One person needs to be made responsible. One of your senior consultants need to be made responsible for that. There are biomedical related issues. One consultant needs to be made responsible for that. There are registrar resident related issues, their rostering, their academics. There need to be somebody responsible for that. There are disciplinary issues across the unit.
Yes.
that somebody else needs to be responsible for that.
Correct.
There is quality assurance of the unit, somebody else need to be responsible for that. And as the team leader, you need to be responsible for all these five.
All this.
See, you can't afford to get your mind diverted from treating a sick patient on ECMO or whatever it is, from a trivial complaint from the family member of a patient who says that your security guard was rude to me.
Okay.
Right? That's a major issue for that family. I completely agree. I will respect that complaint, but my attention is focused on something more serious. So I need to have somebody who will address that, do a root cause analysis, and then discuss with me as a team leader how I can prevent it from happening again.
Correct.
So you need to diversify the points of contact for different verticals in which a successful intensive care unit works.
However small or big unit it is, they should diversify in core areas.
Yes.
And continue the clinical excellence. Yeah. Okay. So how to develop an effective interdisciplinary team coordination, Shrikant? Interdisciplinary, because you will be dealing with so many consultants in a day who are seeing your patients, or you are seeing their patients, and they come and they are not happy with your care. So that's the way we.
Before he says we should get away from this concept, it is your patient or our patient.
Correct.
Patient is a patient. He's come for health care. He's come to the hospital because he's sick. We should not say he's my patient, he's your patient.
But unfortunately, India is
that is the rat. Unfortunately,
open
that is the
ICU.
rat race in which we have got into. We are not saying that this guy has come for medical attention and it is a medical fraternity which needs to project itself as the go-to, not Srikant or me. We should get away from that individual glorification. Then only this will work.
That is what precisely I said when I started talking, that this concept of our practice is based on this concept, and we don't obviously believe that, and we work for the patient, everyone to one patient. So having said that, I think what I believe is it depends upon again it depends upon a situation where you have how communicative you are. I think it is very important, since as Srinivas said that you are a team leader, and everyone will look after you as a team leader who deals with the administrative issues, the nursing issues, and of course the interdiscipline issues, because we have to have that confidence in each other where we call someone and we respect the opinions given by that person. At the same time, it is expected that our opinions are also respected.
Okay.
So it is always, I think it is better to have a very platonic and a tangential equations with the people who come in, with a mutual respect which is given to them. I think that is what I feel.
Okay. Balandu sir, how to address family responsibilities?
Right.
Your own family responsibility.
Right. I think according to Hindu mythology, when one is in Grihastha ashram, he has to attend. There is no question.
Right.
One can't say that I have got big job, big money, so I will not attend. One is in Grihastha ashram, so one has to remain faithful to it.
Right.
So that is the starting point. So that you can't compromise on that. Having said that, if you plan carefully, then you can manage the quantitative component. Suppose you have to go for admission of your son, you have to say no to your work. There are qualitative aspects. Your family wants an outing. They want a trip, and then you got a call. Whole plan is done, and then suddenly it has to be changed. Last moment, cancellation and whatnot. Wife, children, everybody. Now, if the spouse is a medico, then I think my spouse is a medico. It is easier because you understand her, she understands you. Both have similar situation at one time or the other. If spouse is not a medico, then probably I think greater allowance is required. So far as happiness related activities are concerned, after all, what do we want in life? We want happiness, we want well-being. Now, according to modern psychology, happiness is either hedonic or eudaimonic. Hedonic happiness is pleasure. If we go to Goa, if we go to Saputara, if we go to some hill station, we come back, it's happiness. It is very linear. Some weekend off, some happiness. I was reading the literature, it said it has a hygiene-like effect. Suppose आपको हाथ धोना है, ICU में या in canteen, or you clean your hand, you will be happy. But then you clean it 100 times, you won't be happier. So hedonic happiness is limited. But eudaimonic happiness, where there is some fulfillment, you come here, you move around, you learn something. So you have both. Thoda pleasure, thoda happiness. Thoda happiness, thoda bliss. That is very important. So when you are with family, you should gradually convert your family outings into activities of self-growth.
Okay.
Because life satisfaction is a different component, different thing than simple happiness or pleasure. Thank you.
Srinivas, importance of social tech support, and I've heard that you have some extracurricular hobbies as well.
Social support is something as you grow older, you tend to need it more. You think that there was a show of hands and how many below 40, how many above 40. Those below 40 feel that nothing can touch them, right?
Yes.
And they live in that cocoon that everything is safe and everything is good, everything is taken care of, everything is well insured. But life is so fantastic that will change like that. The next morning your insurance is gone, you're on your own, right? So this social support, if you look at the life of an intensivist, I begin my day at 7:30 in the morning and I end at 7 p.m. in the night every day. So I maybe sleep for 6 hours or 7 hours a day, 6 hours probably. So in a 24-hour period, 18 hours I am not with the family.
Correct.
Only 6 hours I am spending with the family, and that time should be quality. You give support and you expect support. The same thing happens with the team as well. Social support doesn't mean your own family members. Social support comes from your team as well. When you are in crisis, not medical crisis, when you are in an emotional crisis, your team will support you if you inculcate that culture in your own team.
Correct.
As far as extracurricular activities are concerned, is my suggestion to everybody sitting here who wants to do intensive care or who is doing intensive care to develop a mentally relaxing hobby of your own when at any age, it doesn't matter. In fact, my daughters are learning painting, and I was telling somebody yesterday that the oldest classmate they have is an 84-year-old lady who's just come in, now to learn watercolors, right? So I can tell you from personal experience that some kind of a hobby like that calms you down like no amount of propofol or midazolam can do. Right? Or maybe alcohol. I don't drink. I don't know how it feels, but maybe I'm sure it calms you down more than the best alcohol in town. Sorry, I'm sitting in Gujarat and speaking about alcohol, but that's how it is. If you have a passion for pets, have a good pet. The joy you get when your pet dog rushes to you when you get out of your vehicle and at home is something you cannot replace. And if you are a music lover, right, who can sing or play music without actually torturing somebody else, it's a good habit. It's a good hobby to have. So be a good intensivist, learn ARDS, learn AKI, learn which fluid monitor you should use for what situation, what fluid, all that is fine. But for you to make a rational decision on that, whatever you have learned today from morning till evening, your mind needs to be calm and working at a very nice pace. And to get that down, you need to calm it down. So to calm it down, you need to have some diversion for your mind.
Yeah. Balendu sir, I think we are finishing the time actually. How about relaxation techniques at work? Can one do it during the intensive care itself?
Yes, I think it is doable to start with simple 1 minute meditation or a prayer. Second is a 90-second reset. You see, the moment you become angry, all the neurotransmitters, they pass through your body. In 90 seconds, its effect is over.
Correct.
So if you act within those 90 seconds, you will destroy the situation.
Right.
But if you simply take 2 deep breaths, ગાંધીજી એવું કહેતું કે રામનું નામ બોલવું 5 વખત. ગુસ્સો આવે એટલે 5 વખત રામનું નામ બોલવું. પછી ગુસ્સો કરવો, ભલે ને? પછી ગુસ્સો આવે જ નહીં. If you have a 90-second reset program, then automatically you will have a different way of looking at the things. And of course, guided meditation and Yog Nidra are very beautiful things. I think we'll have it at some point of time.
Yeah. So to conclude, 6 warning signs if you have, please understand you are having a burnout, exhaustion, substance abuse, relationship problem, depression, tension with colleagues and staff, medical errors happening every time. You're putting a line, it is not going. You're putting IV line, it is not going. That means something wrong is going wrong. So your mind should not be full. You should be mindful, because balance is something what you can't find, you have to create. So why in Gujarat Criticon? Because it is the 5th largest healthcare concern of current intellectual audience which are sitting here, and it will definitely improve your mental health and definitely will follow with your and patient's health. What you have to stress, as nicely said by apt colleagues here, emotional, physical, spiritual, social, psychological, and last is professional. All balance if you make is what we are going to stress, what this take home message is. The tips to have balance are: designate a physician launch, and we are proud, me and Javed, that we have at 5 floors, all floors have doctors launch. We have carom, we have everything at every launch. Offer communication training, teaching mindfulness, we do heartfulness, as sir also does meditation. Organize group discussion, create real-time schedules, revisit shift schedules, foster physician stakeholders, nurture physician leaders. So before your, as Srinivas said, morning, you stop with something, please make your every day as a Sunday, relax and then go ahead. Thank you all.
Yeah.
Thank you all. Thank you.
Thank you so
Thank you all.
much, sir.